Well, thank you so much to Adrian, Manuel, and Jan for the invite and for the opportunity to present today. So just like the previous speaker, I'm going to try to get through this without a single equation in the presentation. That's both a function of the time of the day, as well as the fact that I'm an engineer that works exclusively with surgeons, and no one within about 50 feet of me knows what the balance of linear momentum is. And so we're going to do this all visually, and hopefully it will make sense. So just to introduce myself, my name is Mrudang Mathur. I'm a postdoctoral scholar at Stanford University in the School of Medicine, and I work with Dr. William Hiesinger in the Department of Cardiothoracic Surgery. And today I will be sharing with you some of our recent work towards building cardiothoracic digital twins for robot-assisted surgery. So before I begin, just a health warning. If you're queasy when it comes to gore and blood, I apologize in advance. But no equations, something had to give, right? So, yeah. So that being said, why don't we kick this off? So the first and most important thing is that surgical robots are not autonomous surgeons, unlike what the name suggests. A surgical robot is actually a set of digitally controlled laparoscopic arms that are teleoperated by a very, very, very skilled surgeon. And what makes these teleoperated arms so special is that they permit minimally invasive surgical repairs. No longer do you have to have your chest cracked open for heart surgery. You can make tiny incisions in the thorax, slide a couple of ports in, and have the teleoperated arms go through and repair. So what do these arms actually look like? They follow what's called a wrist on a stick model, where you have a long tube, at the end of which is a joint that has about 7 to 12 degrees of freedom, depending on the instrument that's used. And this can permit fine-grained motion and cutting within the thorax during cardiac surgery. Unlike laparoscopic instruments, where you kind of have to pivot outside, with these surgical robots, you have a greater sense of control while you're inside the patient. Now, robotic surgery is very challenging for cardiac surgeons. It was first introduced in 1998 by Carpentier in France, and this was the introduction of the Da Vinci surgical robot, which is by far the most popular system out there. Since then, it hasn't quite taken in cardiac surgery, unlike urological and general surgery, where it's used most commonly these days. We believe that this limited adoption has to do partially with the large case volume that's required to actually master robot-assisted cardiac surgery. This is about 250 cases for mitral valve repair and around up to 500 cases for coronary artery bypass grafts. And this is for surgeons who have had 4 years of med school, 6 to 8 years of cardiac surgery training, and then 2 years of advanced robotic surgery fellowships. This is in addition to that. What's really striking, and this fact blew my mind, is that the median cardiac surgeon in the US performs only 5 mitral valve repairs annually. And that means most surgeons in the US, at least, cannot possibly be trained to perform robotic surgical repair. Clearly, there's a critical need for better tools for training these surgeons. Now, if you think it's bad for humans, it gets much worse for robots. So cardiac surgery and surgery in general is very much out of reach for robots today. The most popular techniques that are out there, one being imitation learning, is entirely dependent on expert demonstrations. And the sad part is that each action that you want the robot to do, you have to individually provide it anywhere between 200 to 500 expert demos. I met the author that actually performed this, and he spent about 3 months overnight just sitting and tying knots. It was not great. The other approach that people have used towards training robots is something called reinforcement learning, where you sort of plonk these robots or digital twins or digital cousins of these robots into a virtual training environment, make as many different combinations of all the parameters you can possibly think of, and let them go ham. This, again, requires an extremely large volume of simulations for fairly basic functions. And so, again, we don't have the ideal setup to train robots in this. Again, there's a critical need for additional tools to train robots as well. So what's actually wrong with tools right now? Well, we believe they are inadequate, and why are they inadequate? Well, the first kind of training simulator that exists right now is an in vitro one. And what does that mean? You basically take organs from a cadaver, you put it in front of the surgical robot, and then you practice, sort of the old-fashioned, good old way of doing things. This is great because the feel of the tissues, which is the physics, is perfectly maintained, though you sort of have this one lump of tissue on a table, not connected to a human being, not connected to other organ systems, which sort of limits your understanding of what's really going on. So what's the other option? The other option is, of course, an in silico simulator. And existing in silico simulators, you can inject pulsatility, you can inject larger domains, but what ends up happening is that these in silico simulations have to be built purposely for each and every situation. There is, what can I say, a semi-automated way of doing it at best. Hashtag graduate students. And so what we really are aiming to do, I'm so sorry for this, is to build in silico simulators directly from surgical videos. Now, surgical videos are most commonly collected in these procedures. In fact, the Da Vinci robot and other surgical robots have an endoscopic camera which permits the surgeon to actually see what they're working on. And it's very easy to save these videos onto a console as you do them. And so most hospitals actually have a treasure trove of such videos already from patients across diverse physiological profiles as well as disease conditions. But how do we actually pull out an in silico simulator from a video that's captured with one camera? And so for this, we turn to a new technology that's sort of taking the world of computer vision by storm, which is novel view synthesis. So novel view synthesis was first brought to the mainstream with something called a neural radiance field in 2020. In essence, a neural radiance field takes a bunch of different pictures, assumes that there is an object placed between them, and fires rays into that object. And what you're eventually doing is training a neural network to predict how those rays will pass through this object, my bad. Radiance fields are fantastic. They have excellent visual quality, but they are extremely slow to train, and they are extremely slow to render. Think of 0.8 frames per second. For surgeons that have no time in life, this is a straight no-no. So what can we do instead? We turn to a more recent technology, which is starting to replace neural radiance fields out there, which is Gaussian splatting. And I really appreciate Matt coming here and talking about Gaussians and spherical harmonics, because a lot of this work is based on that technology already. So what is Gaussian splatting? It's essentially a point cloud that's enriched by three-dimensional Gaussians that have an orientation, an anisotropic size and scaling, as well as up to 48 channels of spherical harmonics associated with them that can allow their appearance to look differently from each angle that you view them. And what that means is that you can avoid training a neural network on an entire volume. You can instead imbue your scene with a finite set of particles, and those particles will give you the appropriate texture, color, and lighting effects when viewed from different angles. So you can greatly speed up how you view your scene by not densifying it with a full neural network. And so this technology really rests on two key concepts. The first one is structure from motion, which is a very, very old scheme and routinely used in photogrammetry to generate 3D point maps from 2D images. And what this means is that you're essentially looking at the same object from various perspectives and trying to match corresponding points across all the different images. This helps you convert two-dimensional scenes into three-dimensional point clouds. And then what Gaussian splatting does further beyond that is take these three-dimensional point clouds and starts placing these spherical Gaussians on them. And it starts training the model to add Gaussians or densify the scene based on how the visual representation evolves over time. And so we decided to use Gaussian splatting to pull out 3D geometries from these 2D videos that we have. So novel view synthesis is well established for common everyday scenes, and I mean, architectural scenes, buildings, cars, Lego sets, it's everywhere. But there's very little work done on this for cardiac tissues or surgical scenes. And so we went back to the start. We started with a mitral valve that we excised from a heart that was explanted following heart transplant surgery at Stanford. So someone came to Stanford for a heart transplant. They got a new heart. We got their old heart, which we can now use for research. And so what we did was we took a video. This was collected from a mobile phone and off this suspended mitral valve. We then ran the structure from motion algorithm on it. And what we were able to do then was generate a 3D point cloud with depths associated appropriately of this entire scene. And so you see, following that structure from motion algorithm, we get a 3D sense of where these different points lie. Now, this is just from one camera or one frame, but you can imagine that for every frame that exists in this video, we can generate a very similar 3D depth map and point cloud. We then took this 3D point cloud, and we trained a Gaussian splatting model on top of it. And at the end of that, we obtained a scene that we can now arbitrarily traverse, which also has photorealistic imaging effects in it. And so it's a little tough to see on the screen over there, but you'll have to take my word for it. But we went one step further. We're not just looking at building static models. We really want to see what happens when we add dynamics to these models. And to simulate that, we went back to the good old classic uniaxial tensile test. So we excised some pericardium from a wild-type pig. We fixed it in formalin, and then we took it to the Instron on Stanford campus. We then put it in the tester and built a Gaussian splat of it. Now, what we can do beyond this is we can also simulate physics on these Gaussians. And so here, we use a GPU-accelerated material point method to simulate uniaxial deformation on this splat scene. And so with that, we can now enrich these photorealistic scenes with GPU-based simulations. And the beauty of this being GPU-based is that it runs extremely fast. I think this one took around 30 seconds to both run the simulation and render the video at the same time. And at the end of the day, this is a particle simulation. And so if we go back to the fundamental principles, we can apply a homogeneous boundary condition at the base. We pin it, and then since this is the material point method, we apply a velocity to the top, similar to the actual uniaxial tensile test. And from this, when we post-process results, we can, of course, pull out force responses. Now, this is fantastic because we can now use these results to inversely identify material properties should we have the experimental force measurements. Now, what's great in the past year is that most surgical robotics companies have started including force measurements in their arms. So the old Da Vinci that's been out there for years and years, this was a really big problem. Most surgeons complained about it. And I think they finally got around to including that force sensor in. So it's possible for us to now perform in situ uniaxial tensile tests in patients and calibrate material properties as we go. And when I say we, I mean the surgeons, definitely not me. So what's great about novel view synthesis is what you see is what you get. You get a photorealistic 3D geometry directly from a video. Again, I apologize for the gore. But what happens when you can't see everything? What if there are instruments that occlude your view? Or what if there are things out of frame which you, as a human being, through your learned knowledge, know exist, but the machine learning system or the robot doesn't know that it exists? What if we could synthesize what's missing? And so we went ahead and we tried to see if current AI tools that are out there can synthesize medical images. And the answer is not really. So this is from, I believe, this was the Imagine model. And when we gave it this prompt, actually when collaborators at Stanford gave it this prompt, it generated this cartoonish image, which is very much not what this condition looks like. So to overcome this challenge, we built a foundational image generative model that we called Medicine. And Medicine is trained on over 1 million publicly available medical image text pairs across 6 medical specialties and 10 image types. And so those different medical specialties are listed here. We have gastrology, radiology, pathology, surgery, dermatology, and ophthalmology. We got the images and their associated text captions. We pushed them through standard image and text encoders, passed them through, again, a UNet, and learned the noise. So for those who've worked with diffusion models, this is very straightforward. For those of you who haven't, essentially what we're doing is learning how to predict noise in these images and predict the denoising process as well. And so what we can now do is provide a text prompt to our trained model. It generates a latent, which is in a noisy state, and then we pass it through the model to denoise the latent, and then pass it through another encoder to generate a medical image. Now, what does this actually produce? Well, we can produce images from dermatology. We can produce ultrasound images. We can produce more clinical images of the skin, some OCT images from ophthalmology, and a whole bunch more. And most importantly, we can produce images of robot-assisted and laparoscopic surgery. So it's all well and good. We can make these images, but how can we tell if they're actually any good? We went directly to the experts, which are all the surgeons that sit around with us, and we asked them, can you accurately identify the surgical phase or surgical state from real and synthetic images? And we found that the synthetic images were very good for them, and they were able to basically nail the answers to those surgical phases on the synthetic images. We thought, okay, this is great. The surgeons maybe really know what they're doing. So we repeated the same exercise with a bunch of ophthalmologists, and we again see very similar results. This is fantastic. We have some empirical measure now that our images are realistic and at least medically possible. But what if the model is basically spitting out what it was trained on? And so we then conducted another exercise, empirical of course, on whether or not this image model is memorizing its training data. And so based on current standards in the image generation community, we took these images, we embedded them in Biomed Clip's latent space. So Biomed Clip is a big vision language model that's trained on hundreds of millions of image text pairs. And we tried to find the nearest real image to each synthetic image we generated. And between those synthetic and real image pairs, we tried to calculate this metric, which is called the normalized distance, Euclidean distance between the two. We found that most of the images that we generated, and for most specialties, they were significantly above this threshold of 0.15 that's accepted in the image community to be a sign that nothing has been memorized. But we did have a few outliers that did fall below this measure. And upon manual inspection, we saw that even though they sort of gave us the same normalized Euclidean distance that is below 0.15, visual inspection proves that these images are actually very different. And it may just be features like hair on the skin that show up and really pull that number down. So we can safely say that we now have medical images across several specialties. These images look realistic, and also our model doesn't regurgitate what it was trained on. Can we actually use these images now for machine learning downstream tasks? And we believe, again, the answer is yes. So we took some surgical images that we generated for 4 different actions, and we trained a simple classifier to identify these actions. Now, what's interesting here is that we assumed that we had an abundance of real data. So we started our first test with 2,000 real images, our second test with just 1,000 real images, and our third test with 1,000 real and 1,000 synthetic images. And what we found is that the classifiers that were lacking real images, when they were augmented with these synthetic ones, they produced a performance that was similar to the one which had a lot more real images. So we believe that these images that our model generates are sufficient for downstream tasks as well. So to sort of summarize where we're going with this, we use novel view synthesis to recreate surgical domains in 3D from a single moving camera. And the motion here is relative between the camera and the object. Either one has to move. We can then imbue these 3D scenes with GPU-accelerated material point simulations to add physics on top of this entire thing. And then we have a bespoke generative AI model that can fill in the gaps and provide a more holistic picture of the simulation domain, even when we cannot see it directly. And really, our goal is to build a high throughput method for recreating these cardiothoracic digital twins from surgical videos. This method, for our purposes, has to be entirely automatic. We cannot have a graduate student, a resident, a medical student sitting there and updating parameters or manually tracing things out. And so really our goal is to take videos such as this and apply it to all the different surgical videos that exist in these video banks at Stanford and other institutions. And then what we really want to do to go beyond this is to actually use only synthetic videos to further augment this training. And so what you see here on screen are synthetic surgical videos that we've generated that we'll be adding to our next model, which will be called Surgeon. Before I leave you today, I want to give a quick shout out to our work at USNCCM this year. So if you want to learn more about this novel view synthesis process, we have a talk. And we also have a short course on building augmented reality visualizations for scientific results, and especially results in computational mechanics. With that, I would like to thank my advisor, Dr. William Hiesinger, my lab mates, in particular, Joseph Cho and Abhinav Kumar, without which none of the machine learning work would be possible, as well as two very dedicated CT surgery residents, Arvind Krishnan and Matt Duda, that helped collect all the tissues that we used in this work, as well as our funding agencies. And thank you all for sticking out with me till the end of this very, very long day. I'm open to any questions. Yep.
All right, questions for Mrudang?
Thanks. I was wondering why you need to fill in the gaps. Because, the surgeon's going to move his hands at some point, and then you would get data from that, and you get probably the videos are probably not going to be 2 seconds long. They're probably going to be 10 minutes. So essentially, at some point, you would see the whole scene, hopefully.
So that's a great point. And so for parts that are occluded by the instruments themselves, sure, when you remove the instruments, you can see the full scene. But what ends up happening is that this endoscopic camera does not function with a wrist on a stick model. So it's just a really long tube that gets pushed in and sort of is rolled around inside. As a result, there are lots of parts of this surgical scene that are not visible at all. You would end up injuring the patient if you tried to see what was right beside the port of the camera itself. And so there are lots of pieces of the surgical field which follow this, or suffer from the same problem, which is that the camera just doesn't get to them, but a surgeon knows that, okay, this bit of myocardium is attached to the mitral valve on the inside, or they know that this pericardium wraps around entirely. The model or the Gaussian splat does not know that as of now. And so the idea is that we would use the synthetic data to fill in the gaps, but supplement or replace that with the actual data as we see it. We know what a heart looks like, roughly. We can generate a synthetic one. The instant we see one bit of the heart, we can replace that with the first bit, and then sort of keep calibrating this model as we go. The way I think about it is similar to how you add your thumbprint to your phone or your laptop. It asks you to put your thumb down and then roll it around a little bit and then get the entire thumbprint, right? So the same way, we're trying to get the first bit of the heart and then roll it around a little bit, get the next bit, roll it around, get the next bit. But while we haven't rolled it around, we still need information about the parts that don't exist, which is why we'll use synthetic data to start with.
Thanks for a nice talk. Two questions, actually. So the first one is really quick. When you do Gaussian splatting, typically how many Gaussian points or kernels do you have in a given image, and how many parameters are associated with each splat?
That's a great question. So I want to say for each splat, I'll answer the second question first. It depends on the Gaussian library that you use. The one that we used here had 62 parameters per splat, or per point, that is. And then as far as how many we use, it really depends on the kind of geometry that you're looking at. So for this scene that we had here with the uniaxial test, overall, we had about 400,000 splats in there. But what we wanted to simulate was just this clamp and sample. And once we got rid of everything else that wasn't in the simulation domain, we were left with, I think, around 16,000 splats.
Thanks.
All right, yeah, we have time for. I'll run around. We have time for questions.
Oh, thank you. I was wondering, some of the images, like the Karl Storz ends of the tools, are, very like optically non-Lambertian. They're, can you talk a little bit about the effect of the reflectivity on the models?
Absolutely. So that's a great question. The vanilla Gaussian splatting library, which first came out a couple of years ago, does pretty badly on specular highlights and non-Lambertian surfaces. But the great part about working in this field is that the computer science folks are extremely motivated towards solving all of these problems. So I would not be surprised that someone puts out a new Gaussian splatting library that takes care of this next week. Many of the problems that I put in my original talk have since been solved, like between when I got this invite and when I've presented here. So I'm fairly confident that this field will evolve quicker than any of the problems we face in it.
You got a question? All right. Well, with that, let's thank Mrudang.